I have the honor of presenting our speaker today, Paula Braveman, MD, MPH. She's a professor of family and community medicine and founding director of the Center for Health Equity, formerly the Center on Health Disparities in Health at UCSF. Her formal training was in family and community medicine at UCSF and epidemiology at Berkeley. She's worked as a physician at the county hospital, a neighborhood health center, and a school-based health center in San Francisco. For over 30 years, she's studied and published extensively on health equity, health disparities, and social determinants of health, and has worked to bring attention to these issues in the US and internationally. Her research is focused on measuring, documenting, understanding, and addressing socioeconomic and racial ethnic disparities in health, primarily maternal and infant health. During the 1980s, she collaborated with the Nicaraguan Ministry of Health and the Pan American Health Organization to support public health efforts in Central America. During the 1990s, she collaborated with WHO in Geneva to develop an initiative on equity in health in low and middle income countries. She directed the research for Robert Wood Johnson Foundation National Commission on the Social Determinants of Health. And throughout her career, she's partnered with local, state, national, and international health agencies to see rigorous research translated into practice for greater health equity. She was honored in 2002 by being elected to the Institute of Medicine. I'm very happy to have her speak about the Black-white disparity in preterm birth. Is racism a missing piece of the puzzle? And to reconnect with her after many years, because she and I went to high school together at North Miami High School down in Florida. So welcome, Dr. Paula Braveman. Thanks for joining us.
Well, thank you, Phil. This is a pleasure. Reconnecting with you is a pleasure, and doing this seminar is a pleasure. Probably would be a greater pleasure if we were all in person, but we're grateful to have Zoom. There has been a large and very persistent disparity, Black-white disparity in preterm birth for a long time. It would be difficult to come up with a health indicator that was more important than preterm birth. It's a very strong predictor of infant mortality. Among African Americans, it's the #1 predictor of infant mortality. It's #2 among whites. But preterm birth also predicts significant disability in childhood, physical, emotional, mental disability. And then more recently, we've learned that it's a predictor of chronic disease in adulthood. Tremendous burden on families and associated with huge economic costs. So unfortunately, the causes are unknown, although there are a ton of hypotheses about what might be the cause of the Black-white disparity. And I want to caution you right at the beginning to make a distinction between what could be a cause of preterm birth and what could be a cause of the Black-white disparity in preterm birth, because those are not necessarily the same things. I think for a long time, people assumed that once African-American women received prenatal care, that we'd see the disparity go away. There have been a lot of, frankly, racist assumptions about substance abuse being involved, and both of those, the role of prenatal care and the role of substance use in the Black-white disparity, have been disproved with empiric evidence. The disparity is also not explained by current income or education of a woman around the time of childbirth. And the fact that it has not been explained by the most common socioeconomic indicators has made many leap to the assumption that it must be genetic. And I'll talk more about that a little later. But I'm not going to go through this list, but you can see this long list, and actually it's not even an exhaustive list of the factors that have been thought to contribute to the Black-white disparity in prenatal care. And there actually is certainly biological plausibility for all of these factors making a contribution. I'm sure for this crowd, the environmental exposures is of greatest interest, and that's one of the areas where the evidence is strongest, that as a contributor to the Black-white disparity in preterm birth, that it's an important one, and it's because of environmental injustice. A lot of people have assumed, as I mentioned before, that this must be a genetic difference because it hasn't gone away when they've controlled for income or education. I've been part of a work group that was assembled, convened by the March of Dimes to look at the Black-white disparity in preterm birth. And it's a work group that has lots of biomedical people on it, including a few with genetics expertise, and then there are a few other social epidemiologists like myself. And after study of what's out there in the literature, this panel concluded that at most the contribution of genetic differences to the Black-white disparity in preterm birth at most is small. Now, gene-environment interactions are another story. That could be very important, and I think a lot of people are betting that that's going to come out as a very important thing. Where I stand in all of this, and a lot of my colleagues, is raising a question about racism, whether racism could explain the Black-white disparity in preterm birth. So we'll explore that a little more. There's a lot of evidence that strongly suggests that if you want to explain the Black-white disparity in preterm birth, there are social causes there. You have to look at social causes. One of the most compelling pieces of evidence that makes it unlikely that a genetic explanation would be applicable is that a few studies have been done showing that women, Black women who immigrate to the United States from Africa or from the Caribbean, that their birth outcomes, including preterm birth, are very similar to those of US-born whites. I think it would be very difficult to explain that one with a genetic hypothesis about the causation. But there are other pieces of evidence telling us that there's something social going on there. One is that in the literature, the disparities, the Black-white disparities, often vary a lot with features of the neighborhood, both physical features and social, especially social features. In addition, if you look just at poor women under the poverty guidelines, that among poor women, Black and white women have similar preterm birth rates. That's another one that I think is very hard to explain with a genetic hypothesis. And there's now a growing literature, not insignificant, but it's growing, of studies that have linked experiences of racial discrimination, just different kinds of experiences of unfair treatment, including insults or threats, or the vigilance that those experiences prompt, linking experiences of racial discrimination with preterm birth. And that in the literature also, stress seems to be very, very important. So racism, if we think about the hypothesis, is it plausible that racism could be something that explains the Black-white disparity in preterm birth. Let's look at racial segregation. An excellent example of structural or systemic racism, and as with other structural and systemic forms, it's something that gets perpetuated even if there's no individual or individuals who are intending to discriminate, because it's embedded in the structures and it's self-perpetuating. And discrimination in housing is no longer legal, but the legacy of Jim Crow endures in pervasive racial segregation. Segregation tracks Black people into neighborhoods that are less healthy in many ways, including exposure to pollution, unhealthy foods, and the stress of living in deteriorating areas with concentrated poverty and the desperation that accompanies concentrated poverty. This affects not only poor, but many middle-class African Americans. Segregation cuts Black people off from services, from good schools, from decent jobs, from economic opportunity, and from hope. All of these perpetuate low socioeconomic status, SES, and poor health across generations. And all of this can happen even without any individual consciously intending to discriminate, because it's structural racism. It's built into the structures, the policies, the established practices, the deeply entrenched beliefs. Low SES could affect preterm birth risk in many ways, including through poor nutrition, toxic exposures, and the stress of constantly facing daily challenges like childcare, transportation, and feeding and sheltering your family without adequate resources. But most studies measure socioeconomic factors very inadequately. Often it's just one measure, at best 2 measures, which is not enough. We have found that the racial disparity in preterm birth, we found it to be reduced by about a half after adjusting for just a few socioeconomic variables, but just a few, but more than normally routinely get adjusted for. So I want to highlight the issue of unmeasured differences. That structural racism has constrained African Americans' economic opportunities, resulting in less favorable education, employment, income, wealth, and neighborhood economic advantages starting in infancy. But how often do you see papers concluding that an observed racial difference in health must reflect underlying biological differences or behavior because the researcher saw a racial difference after they controlled for SES? It's not possible to control for SES. No one can. It's too multifaceted. It's too multidimensional. It's not just your income or your education, but both of those and your accumulated wealth, the quality of your education, not just the quantity of it, your neighborhood's socioeconomic conditions, and your parents' education, income, and wealth when you were a child. It's all of these factors and more throughout a person's life, and no one can capture all of it. Because of racism, at the same level of income, Black and Latino people live in poorer neighborhoods and have a fraction of the accumulated wealth. And all of these differences can affect health. There's a rich literature on those linkages. Yet these factors are barely measured, but studies often conclude that a racial difference is genetic if it persists after control for SES. So race often captures unmeasured socioeconomic factors. Now, I've just noted how structural racism could lead to preterm birth by lowering SES, but racism also could plausibly affect preterm birth through the direct psychological effects of experiencing, anticipating, or just being aware of unfair treatment. And there's a literature on all of those issues, the anticipation, the being aware that your group is experiencing discrimination, those in addition to suffering over incidents yourself. All of those have been tied to stress. So it's the cumulative effects of daily experiences that may be subtle or ambiguous. It's the effects of being constantly vigilant for a slight or an insult to occur, intended or not. It's the cumulative effects of countless tiny little assaults on one's self-esteem, or maybe the effects of learning that yet another unarmed Black man has been killed by the police and constantly wondering whether your husband or your son is next. So chronic stress, even at a low level, is biologically plausible as a contributor to preterm birth through neuroendocrine and immune mechanisms. And what has been learned, neuroscience has made these leaps in the last 20 to 30 years, but I think that they have very much, a lot of those leaps have informed our understanding of how racism can affect health. And what has been observed pretty consistently, that even a low level of undramatic, relatively undramatic stress, but a low level that's persistent, that's chronic, that's what seems to do the damage. That's what sets off the neuroendocrine mechanisms that lead ultimately to inflammation and to immune dysregulation, and which lead to chronic disease, and have also been tied to these same mechanisms have been tied to preterm birth. So the neuroscientists have identified the physiologic pathways leading from stress to health damage, not specifically preterm birth, but health damage in general, and particularly chronic disease. So including these effects on inflammation and immune system functioning that are known to trigger labor. So my colleagues and I found a couple of years ago in a large statewide population-based study in California that the Black-white disparity in preterm birth was no longer significant after adjusting for whether a woman often worried about being treated unfairly based on her race. So how many health studies have you read that measured people's experiences of racism? I'm not saying that our study was definitive, but it's in line with a literature that makes it highly plausible. So I'll bet that the number of health studies that you've read that measured people's experiences of racism are precious few. It's pretty much going to be in those studies who are studying studying a different outcome, actually focusing on racism and health. But in the 99.9% of other studies that are not focusing on racism, how often do you see a covariable in there that is representing something about the experiences of racism? So this work group that I mentioned, convened by the March of Dimes, has concluded, I mean, after studying the literature for quite a while, that it is very plausible that racism could explain, in fact, almost all of the downstream factors that are biologically plausible, and that no one could come up with another factor like racism that could do that. And this work group also concluded, and I mentioned this before, but I'll repeat it, that the genetic contribution to the disparity, to the Black-white disparity in preterm birth, is at the most very, very small. This is just to show you just one of the causal pathways that is thought to be very important in actually stresses effects on many, many health outcomes, but particularly chronic disease outcomes and preterm birth. So where we experience a stressor and that gets registered in the hypothalamus, and then the hypothalamus sends a signal, CRH, to the corticotropin releasing hormone to the pituitary gland. And the pituitary releases a chemical signal, ACTH, to the adrenal glands, and then the adrenal glands pump out cortisol. And that if it's a brief, acute exposure to cortisol, it does not look like that is damaging to health. It's the prolonged, when this axis, the HPA axis, as it's called, when that is chronically activated, that it looks like the danger is to health, and particularly in relation to chronic disease. So I've concluded, and this work group actually concluded, that racism may be a very important contributor to the Black-white difference in preterm birth and other adverse health outcomes, and through at least two major pathways. So one pathway is indirect, through constraining the socioeconomic resources and opportunities that someone has. And then the other pathway is more direct, and that's the direct psychological effects of experiencing racism in a whole spectrum of ways that people experience racism. So both of these pathways can get activated, both the constraining socioeconomic status and the direct stress causal pathways involving stress effects can occur even when no one individual now in this year intends to discriminate. But neither one of these factors is usually measured adequately in health studies. So I've been focusing on preterm birth, but the key points I'm trying to make, particularly about plausible causal pathways from racism to health damage and about unmeasured differences, they are relevant to a very wide range of health outcomes, and particularly chronic disease, where the roles of inflammation and immune dysfunction are believed to be important, as they are in preterm birth. So in closing, I want to appeal to you that when you conduct studies or when you read studies that include a variable that's representing race, that you need to be aware that regardless of what else it may represent, the race variable is always picking up the totality of unmeasured experiences that a person of that race may have had throughout their life course, which could have had health effects. And you could have measured at best only a tiny fraction of those experiences. So I want to urge you to ask always in a study, in designing a study, interpreting the findings, reading a study, are you looking at race or are you looking at racism? Thank you. I'll look forward to the Q&A now.
Thank you, Dr. Braveman. For those of you who have questions, and I'm starting to see a couple of raised hands and a couple of claps there, why don't we go ahead and have you use that raise hand function to state that you want to ask a question. People are using, to be able to find this, you should be able to find this if you open up your participant tab. You'll have 3 dots that show you the ability to raise hands. There's also many people will have a reactions button at the bottom of their screen. And when you click on the reactions button, you can do a number of things. There are clap functions, thumbs up, but there should also be a raise hand ability through that functionality. And if you don't have those, you can take yourself off your mic when they're, unmute yourself when there's an opportunity. And I see somebody with a raised hand, bear with me. It's hard telling the raised hands from the claps. And thumbs up.
I don't have or I couldn't find the icons that you were talking about, but I do Jane Cawley raised a hand.
Yeah.
Yes, thank you very much, Dr. Braveman. It was really interesting. I wonder if you were saying most studies don't measure or include measures of racism. And, you know, we need to start doing that. Are there standard scales that have been validated, or could you point us to any ones that you use in your studies?
There are a couple that I think have been used most frequently. Unfortunately, I think they're probably too long to be incorporated in most studies. You know, I know that I don't have, you know, in the data sources that I've had, I do not have the option of having, you know, 15 variables, you know, to measure a, you know, basically a covariate kind of concept. But the measures that are used the most were developed by David Williams at Harvard, and the other by Nancy Krieger, also at Harvard. I have used the data source that I have been using for quite a while, because I work on this data source. It's a survey that is supported by the state of California Maternal and Infant Health Survey, and the studies that there's a dance between I think my colleagues at the state you know, want to see some good research come out of that survey, but I rarely have the opportunity to, you know, to add lots of questions on a, you know, on a single issue. So my colleagues and I have developed a couple of measures, a few measures, but I can't say that, you know, that we've done validation studies. We've looked at whether, you know, we thought we were getting, whether it seemed plausible that we were measuring what we wanted to measure. But we have felt that we need to measure both. So both the Krieger and the Williams scales are really about incidents of being treated unfairly. But we also need to ask about worrying about being unfairly. And I mentioned results of a study that we did with that, which were actually more dramatic even than we were expecting, because the Black-white disparity became non-significant after we controlled for that variable, the worrying often, either often or very often, about being treated unfairly. And then there's a third question, and that I think is important, and that is being worried about your loved ones experiencing racism. In a qualitative study we did quite a while ago, where we just asked women to talk about their experiences of racism without us defining what we meant by it. We were very surprised that a lot of what they talked about was the worry about being treated unfairly. And then a lot was worrying about loved ones, you know, children, husbands. So I think those are, you know, those are three dimensions that should be covered. I would be glad if you send me an email. I'd be glad to send you what the questions are that we've been using. But again, with the caveat, they haven't been formally validated. Both the Krieger scale and the Williams scale have been formally validated.
Okay, thank you.
Sure.
Susanna, do you want to take yourself off next? Great.
Yeah, hi, thank you so much. This was a great talk. I'm sorry that I came in towards the end of it, so pardon me if this has already been mentioned, but I just wanted to sort of bring up the issue of the adverse outcome of stillbirth as sort of part of the whole continuum of perinatal adverse outcomes, and how in the States, the Black American stillbirth rate is double that of white Americans. And I think that the discussion you're having about racism-related stress and its effect on stillbirth is something that's under discussed, under researched, under reported. And so just to make a plug for folks who are looking at the effects of racism on adverse outcomes around birth, to include stillbirth as one of those.
Well, and I would just like to underscore that it's really important. It's thought that the disparity is probably even greater there in stillbirth than it is in preterm or low birth weight.
And Susan LaRoe, would you like to ask your question?
Yes, thank you so much. I appreciated hearing about that. I'm an OBGYN in Pittsburgh, and I'm curious if you could give any suggestions in terms of offering prenatal care, what interventions you would think would be most effective.
That's a very tough question. And, I think that the evidence is there that preterm birth, we're not going to be able to make a serious dent in it without some big societal changes. So we need to launch ourselves on a path toward those changes, but there's probably not going to be one, silver bullet that anybody can use. There are some attempts to have groups of pregnant and postpartum women who get together, and and the focus is on the general focus is on the pregnancy and pregnancy health, and then on parenting, but to actually address racism in those groups, and it's plausible that could help, but it seems that you need to be in a place where there are enough Black women, that you have enough Black women for a group of Black women who are pregnant at around the same stage of pregnancy, because it doesn't look like this would work in a mixed group. That it really some of the that the magic is in the social support for each other, and in feeling free to say anything about their experiences of racism, that probably unlikely that an African-American person is going to feel as comfortable about that in a mixed group. Anyhow, some have tried, basically using the centering pregnancy model, but constituting separate groups of Black women and having content that specifically addresses racism. But my colleagues and I actually, quite a while ago, with funding from the Kellogg Foundation, we developed some materials that people could use for an intervention focused that way. But it is such a tiny fragment, what that can touch, that can't touch women's experiences of the world, which are, so much more powerful but by the same token, that stress is a very plausible, and I think there's actually nobody who studies preterm birth now who doesn't agree that stress is very, very likely to be a player in this. If you believe that, then it is reasonable to think that social support could be helpful, because social support has been shown to buffer under certain conditions, to be able to buffer the health damaging effects of experiencing stressors. So that, that could be with, I mentioned that because that could be something that's within reach for an obstetrician, even, developing your own approach to it. I would be glad to share these materials that we developed, but I feel like it's such a sort of pathetic, tiny little, fragment of what needs to change, which is more, in our, it's more in our society, and it's at the policy level. So I don't have.
That's very helpful. Thank you.
Dr. Braveman, we have a few more questions. I'm going to try to go in the order they came up on my screen. Judy Zelikoff was next, if she can unmute herself.
I can. Thank you. That was excellent. I'm coming at it from a different perspective, but I want to make it clear some of the things that maybe people on the call haven't thought about. So I'm a toxicologist from NYU Grossman School of Medicine, and I work with animal models in preterm birth and environmental exposures. And I just want to put it out there that there are definite animal models of preterm birth. We have found environmental contaminants, including air pollution, particulate air pollution, and many other factors bringing about preterm birth. And I wanted to just put out there that many, in terms of the epidemiology and the associations, many of these things that you've discussed can also be evaluated in animal models to actually get causative relationships. And so we can, we and others throughout the US and the world, you can study things like nutritional deprivation, crowding, environmental contamination, intruder behavior, comorbidities, social stress, isolation, and all of these things can provide weight of evidence for the epidemiological studies and move away from those genetic orientations and put some science, sound cause and effect relationship together with the epidemiology. Thank you.
Yeah, and that's, I think I said this, that in the area of environmental exposure is one of the strongest areas of evidence for the causation of preterm birth.
And I'd certainly be happy to collaborate with any of you. And thank you, Dr. Braveman, that was excellent.
And then Jose Cordero, I believe, was next, if you can unmute yourself.
Thank you so much for a great presentation. I'd like to go into one of the points you made, and it was that in Caribbean and other immigrants coming to the US, the rates of preterm birth tend to be actually as low as whites, and often basically the levels that they are in the respective countries. Something that at least there's some data in Puerto Ricans is that second generation tend to have a higher rate closer to African Americans. And I wonder if that sort of first generation, second generation differences may be an area that can maybe provide us some ideas or evidence in terms of what are those factors that are different in that population.
Is this the same Jose Cordero who is part of the work group with Marcha?
Yeah, it's me. It's me.
Oh, hi, Jose. How are you? I was thinking, how many people named Jose Cordero? I know. So it's a pleasure to hear your voice. And yes, I mean, it's such an instructive way to go, I think, with research. Unfortunately, it takes huge resources. But there was a study that was done in Illinois, and I'll bet you know about that study, Jose, but a study done in Illinois over 15 years ago, in which some researchers looked at the outcomes. They had this longitudinal database that was supported by the state. I think it's unique. And, what they saw was the good birth outcomes that Jose just mentioned, the birth outcomes like those of white women among the African immigrants in that first, the first generation. And then what they saw was in their daughters' birth outcomes, that next generation, that's where the outcomes looked like those of US born African Americans, very bad. It's a pattern that, cries out, tells us that there's something toxic. What is it that's toxic in the social and physical environment of living in the US that would do that? It's a pattern, of course, that's been seen among Latinos, exactly that pattern with the good birth outcomes among the women who have emigrated here but were born in a Latin American country, but then their daughters have the bad birth outcomes afterwards. And it seems so important to do that. I guess no one has had the resources to mount a study like that. There's no other state that has a database like that one in Illinois. So I agree with you that that's a really rich area that should be explored.
Thank you. Thank you very much.
No, thank you.
And then the next question was David Gonzalez, if you were able to take yourself off mute.
Hi, thank you for this talk. I had a question, it's in two parts. One is the idea of like a biological versus like a social construction of race. So, for there to be disparities explained by genetic factors, race would have to correlate with genetics. And my understanding is that race is a sociological construct without a biological basis. So I'm wondering like what the theoretical considerations are for examining disparities with respect to genetic differences, whether that is something that you should be putting any resources into. The second part is just thinking about like experiences of racism that may mediate the effect, may be explanatory for these disparities that we observe, how that might be extended to other racially marginalized groups with these disparities. We were just talking about Latinx populations, also indigenous Native American communities as well. I'm just wondering to what extent do we need to be thinking about the like just the subtleties or the differences or the nuances of experiences of structural racism.
Okay, well, should we be studying genetic causes of the Black-white disparity in preterm birth? I think it's helpful to accumulate the evidence to be able to disprove the theory that it's genetic, but if I can make some assumptions about where you're coming from, and I can say that perhaps you too don't appreciate that. I mean, the resources that are going into that when there are so many more fruitful areas to investigate. If you just think of the wealth of evidence that we have that that social factors are involved in the preterm birth disparity, the Black-white disparity, right there, even, without the genetic studies, that tells us that the genetic area is probably not going to be very fruitful, right? So I think that it ultimately comes from a very deep level of racism and sort of racialization of people. The fact that that's what the research community gravitates toward studying is the genetic difference, and when areas, I mean, what Dr. Cordero just brought up, looking at the generational changes in birth outcomes, and could be very helpful to us, and having some really strong longitudinal studies that are really rich in social variables, so both socioeconomic variables and other social variables. The money that is going into the genetics studies could be better spent, I believe, in this other direction. But I think, given the reality that that these beliefs are there, I mean, I was very happy when the geneticists and the biomedical types in this work group that Dr. Cordero and I have been on, when they, came to their conclusions about the contribution being small, if any, and that I think that it's very helpful for us to be able to say, that people who've studied this believe that it's small.
Yeah, also, just to add one point, there's studies that show that among biomedically trained, people with biomedical training, there's a misconception that race is biological, and this is far more common than people with sociological or like more social science training, where race is understood to be a social construct. So it seems like maybe resources towards education for people in the biomedical community could then help us get to redirecting those research resources and energy, like you were just saying, towards understanding the social construct.
Right. And then your question about, should we be raising these questions, about other racially marginalized populations? Absolutely. It's difficult. American Indians, Alaska Natives have some of the worst health outcomes of any groups, but it's expensive to study them, and to get a study that's large enough to get statistically significant results is quite a feat. So I think it would be worth it, and it could inform our understanding of causation. But we're going to have to fight for the resources to be devoted that way.
Dr. Braveman, we have about 3 more questions, if we could try to fit them. Phil Brown is next, I believe.
Okay, if you hear me, that's good, because it won't let me start the video. It says it's disabled. Do you hear me?
I can hear you, Phil. And hi.
So I thought the answer to the intervention question was really great. And of course, Centering Pregnancy is a wonderful program. Gudji Cook from the Akwesasne Mohawk community told us about that when she spoke here 5 or 6 years ago. But ultimately, you point to a social organizational aspect. So I was putting together thinking about how civil rights organizations took advantage of the OEO programs in the 60s to say, if we want to combat racism and support civil rights, we need to organize. Our own NIEHS has fostered the development of community groups in the grants they've made. And Tom Leviste, who did this as his dissertation years ago, found that where you had Black political representation in cities, you had a lower infant mortality. So that was like the really structural kind of answer. And then the last part of this is Stacey Abrams' op-ed piece in the Times, I think it was last Sunday, saying, here's what we did in 10 years in Georgia and flipped the country with community organizing. And the role of getting Black women, not just Blacks overall, but Black women in particular, which is a lot of her focus. But that really made a big difference. So if we could put together our efforts as professionals and also be advocates and activists, isn't that what we need? It may be communities that have more EJ groups, more reproductive justice groups, more Black Lives Matter groups, and many other kinds of organizations have better outcomes. That's the thing we should study as a direct study of racism and anti-racism on health.
Well, I'm so glad that you articulated that, Phil. I think you're really right. And it's, the term empowerment is sometimes a problematic one, but we need to basically, people who've been excluded and marginalized need to get more power in order to change the structures that are perpetuating the injustice.
And then Ketchaweo, Rashid, and I apologize if I mispronounced your name.
Okay, yes, it's CTWAO, Rashid. I'm from the University of Kentucky. Excellent talk. I just was wondering, so systemic marginalization, it isn't unique to America. So I was just wondering if you've seen this in other countries.
Have we seen this in other countries?
Yes.
Well, let's talk about the Nazi Holocaust in Germany. That's the most dramatic one. But yes, we see, the in-groups and the out-groups in other countries. We see, France is seething right now with anti-immigrant feeling. I think that the human tendency to look for someone that you can feel better than, and someone who can be exploited for your benefit. Unfortunately, it's very universal. Do we see it having the same kind of fury as the racism in this country? I don't know. It has seemed to me, from the time that I've spent in Europe, there's racism there, but it has struck me as somewhat less, for the most part, somewhat less virulent and less hate-filled.
Okay, so do you see the same disparity in preterm birth in those other countries?
It hasn't been studied.
Okay.
Yeah, and specifically in Europe, people don't even like to use the word race much in Europe. They just talk about ethnic groups, and that's a reaction to the horror of the genocide in World War II. I'm actually working on a paper right now that's recommending taking that position, that we should stop using the term race, because it is irremediably imbued with the notion of biological difference, and that ethnic group is actually more, that's a lot more justifiable if we look at what it is. We've got these large groups that with ancestry in different continents, the European American and African American and Asian and Native Hawaiian, Pacific Islander, Latin American, and they're meaningful because they're socially recognized, and because to some extent those categorizations reflect a common history, and sometimes language, but it's fundamentally social. The notion of an ethnic group and the notion of race is fundamentally biologic, and I feel like getting rid of the term would be helpful. It's a tiny thing, but put that together with other things, it could be helpful.
Thank you.
Dr. Braveman, if you could take just one last question. I realize we have gone a little bit over. We have Amina, who has been waiting patiently. And Amina, if you can take yourself off mute. Thank you.
Yes, hi. Thank you so much, Paula. This was great. I mostly have comments. First to Rashid, I want to say that if you look at Australia, they have very high disparities, especially in pregnancy outcomes, stillbirth, etc. And their systemic issues are very similar to the US, and they do have disparities, high rates of disparities between Aborigine communities and the mainstream. So you could probably look at that. The other issue is the genetic factor. Again, these are just comments. I am an anthropologist working in public health, so I totally get the social part, extremely important, but I don't want us to discount the genetic changes that the environment causes. So I think it would be interesting to look at Blacks in Africa, for example, and Blacks in the US, and look at how the environment has actually changed, impacted DNA and genetic material here among Blacks in the US. So I think that would be interesting to look at everything from looking at accelerated aging, such as telomere length, for example, or other genetic modifications that could explain some of these disparities. So just a suggestion, but that's all.
But I think you're really right on the mark, and there are a lot of people doing research on preterm birth now, and on the disparity, and believing that gene environment interactions could be very, very important. But of course, the conclusion, if it's gene environment interactions, would probably more accessible to do something about the environment rather than to work then on gene therapies that are going to, make some biomedical company more wealthy. Especially if the environment, the environment includes the social environment and experiences of discrimination or experiences of financial hardship. Any source of stress. It's believed that stress can certainly trigger a gene environment interaction.
Thank you, Dr. Braveman. Thank you for taking a little bit of extra time too. We really appreciate the talk and the time that you took to give to us today. So on behalf of Protect, I want to say thank you very much, and let the audience know as well that you've kindly allowed us to post the recording. So the recording of this webinar will be made available on our website for anyone who would like to share it with others or listen again for themselves. So thank you all, and very good talk, Dr. Braveman.
My pleasure.